performance. But we know that this government came to power not just promising to fix the NHS, but to boost the health of the nation and to close large and persistent gaps between communities in Britain. Also came to power focusing on children's health, thinking about how we can boost the health of children and young people. The government set a short-term milestone around clearing the elected backlog, but that's also part of a longer-term mission to boost health and life expectancy and cut inequalities between the most and least deprived communities. Clearly, and I'm sure there'll be a lot of reflections on this, that will require changes to the way in which we organise and deliver healthcare, but it will also be about making sure that health becomes everyone's business across government, and we take a properly joined-up approach to tackling things that make us ill or supporting the things that keep us healthy in the places that we are born, that we live, that we work, and that we age in. We know that 90% of health outcomes are not to do with healthcare, and in order to really boost the health of the nation, we're going to need a different approach. We recognise the constraints in which that operates in, record pressures on the NHS, often for those who work in clinical roles, and feeling of unrelenting pressure on services at the moment. So the discussion today is about how we make sure that we maintain momentum against that long-term mission in the context of a tricky fiscal reality and in a situation where pressures on NHS services are enormous. So with me to discuss that challenge, I have three brilliant speakers. Firstly is Dr. Zubir Ahmed, who is the newly appointed Parliamentary Secretary of State at the Department of Health and Social Care, also a vascular surgeon. We've got Dr. Sonia Abasara, who is the Vice Chair of the Fabians and a GP. And last but not least, I have Peter Babudu, who's the Executive Director at Impact on Urban Health, and he previously held leadership positions at the Youth Endowment Fund Research and Innovation Partnership. So enough from me, I'm going to pass over to Dr. Ahmed for opening comments.
Well, thank you very much for having me here. And it's nice to see a packed room. You're obviously very interested in health policy and outcomes, so it's good to hear. So, we're all Labour people, or Labour-minded people, that's why we're here. So I think it is important to think about some of the statistics that have changed inside the NHS because we have a Labour government. Waiting lists are down. We do have 5 million more appointments in the system than otherwise would have. There are people getting hernia and hip replacement operations that otherwise wouldn't have had them and would have had to continue to deteriorate on their health journey. So that in itself has a preventative element. But I'm under no illusion that alone does not by any means make a prevention strategy. And in some ways, what my job and the Department of Health's job is not to think of prevention as an end destination of years and years of cumulative bits of health policy, but it's something to infuse inside almost every decision that we take and make. And obviously at the moment, particularly with my portfolio, we're thinking about how in a fixed envelope, as much as the Chancellor gave us a good budget and a good spending review, relatively speaking, compared to last time we were in government, a fixed envelope, how we transform the National Health Service. And I'm doing it through a digital lens. And I think the digital lens has a lot to do with how we speak to prevention. Because what it's about for me fundamentally, both as a clinician, but also as a patient and a relative of a mum that's got multiple health conditions, is how you empower the patient with their own data. Because that isn't only about getting over the trust barrier that some people have with digital health, but it's also about citizen responsibility for their own health. It's about how we live more of our hopefully extended life expectancy in good health. And it's wrapped up, for me it's wrapped up in the digital environment. Because if we're going to use digital as the transformation agent, it's got to be the agent where you interact with more of your health quicker, more easily, in a digestible fashion, and that gives you access to services, advice, mentorship, nudge, whatever you want to call it, to make sure you stay healthy for as great a part of your life as possible. And I think, in years gone by, clinicians, and I was one of them, was a little bit reticent about letting patients maybe see more of their data, because what would that mean for me at an individual level? Maybe it would mean more work for me. But actually, we have to get over that, and we have to build at system level, at organizational level, ways of being able to communicate with patients once they see that data. Because I think it's fundamentally the only way we change the dial. Because we're in a worrying situation right now, and I'm in my 40s now, and more 40-year-olds are unwell now than there were in my parents' generation, right? Because more of them are overweight, more of them are carrying cardiovascular risk, despite all the statins and aspirins and ACE inhibitors have been throwing at people for the last 20 years. And that's a really sobering thought for me. And there's got to be something in the digital space that allows people to change their behaviour. So that's what I'll be concentrating on. As much as digital will be delivering the left shift, it will be delivering reduction in waiting lists, it will be delivering a new way of doing clinical pathways in primary care and secondary care. Infused throughout it has to be that citizen engagement for me before they become even a patient. So I'll just stop and listen to what people's thoughts are.
Good afternoon, everyone. It's great to see such a packed room. First, I want to apologise because I had written out a really coherent, interesting speech which I left in my hotel room. So now I'm going to have my incoherent rambles. My second apology is normally I get tonsillitis after conference. I've now got it on day one, which I think shows my age. So I'm struggling with my voice a bit, so I'll use this microphone. So yeah, my name's Sonia. I'm a GP, and I often get asked at my Labour conference, like, what are you doing here? What are you doing? Why are you a doctor at conference? And I guess we all probably have moments in our career or in our lives that have politicised you. And one of the real, I guess, politicising moments for me was when I was a junior doctor. I was working in an A&E department, and we had a child brought in by ambulance who had had an asthma attack at home, and we spent about 45 minutes trying to resuscitate him, but he died. And it was a politicising moment for me, because asthma attacks or asthma deaths shouldn't happen. You know, when we're in med school, we learn that it's a never event, it's a preventable death. And yet, we have one of the highest childhood mortality rates from asthma in Europe. And I thought about this recently when I was actually in my staff room in my GP clinic, and I was just overhearing two of my colleagues talk about a death that we had recently of a baby, so all deaths get looked into, unexpected deaths by a clinician. And my colleague said something along the lines of, not sure yet of the cause of death, but nothing we could have done differently from a healthcare point of view, but there were lots of social factors involved. And that phrase, social factors, just stuck with me. It's a phrase that I guess maybe clinicians in the room, it's been used quite a lot, particularly where I work in Tottenham. But it's quite a innocuous phrase that essentially means, despite everything that we do as clinicians, despite our NHS, despite all the advances in modern medicine, kids growing up in my area, my patients, are more likely to be sick, more likely to have chronic conditions, more likely to have severe mental illness, more likely to be admitted to hospital, and are more likely to die, more likely to have an early preventable death. So statistically, babies born in the area that I work before the age of 1 are at a 2 times increased risk versus babies who are born in Westminster area. And on the face of it, this appears to be getting worse. So a snapshot done by the Royal College of Paediatricians this summer found that 78% of the paediatricians that were surveyed said that what they were seeing, the impact of poverty on ill health and admissions that they see, had been getting worse over the past 2 years. So I mention this because I think it's quite easy for us to, for the political focus to be focused on what we're doing in the NHS, but we won't be able to reverse these statistics, these quite horrendous statistics, if we don't explicitly tackle the drivers of ill health. Yeah, unless we explicitly prioritise public health over vested interests. And unless we have a vision and a coherent plan that is cross-government and that has actionable targets that we're all held accountable to. And we need to have conviction in that vision and what we're trying to achieve. because this won't be easy. You know, I think I'd say, you know, bringing down NHS waiting lists is easy. No one's going to argue with that. But, you know, getting people out their cars doesn't always go down well in focus groups, right? You know, tackling the food industry, changing our urban environments, improving our air quality. These things are complex. These things are politically difficult, and these things will require us to take on vested interests. But I guess, you know, I want to take you back to the case I said at the start of that kid who died in my area. Today, if you have asthma and you're living in one of the poorer areas of the country, you are at a 4 times increased risk of dying than kids living in wealthy areas. Now, I don't think anyone in this room should be comfortable with that statistic. And I don't think anyone in this country is comfortable with that statistic. So I think 1 year on, we need to remember why we are in government, what we are trying to achieve, and we need to be focused, we need to be bold, we need to have conviction in the difference that we're trying to make in this country, and we cannot waste this privilege and this opportunity that we have of being in government to make a difference to the children's health of this country.
Thank you, Seb. And thanks to IPPR for hosting this event with us. So yeah, I'm Pete. I'm the Executive Director of Impact and Urban Health. We're part of Guy's and St Thomas's Foundation, so one of the largest health foundations in the country. And we try solutions to some of the knotty health challenges, particularly those that Sonia was talking to. And we try out solutions in our place that we think can work across the whole of the country. And a kind of spoiler alert for me, I think the government has the right mission in wanting to raise the healthiest, happiest generation of children Britain has ever had. But we are just incredibly far from that at this present moment. So there's available evidence from research that IPPR has done, as well as other research we've conducted and commissioned, that just speaks to how far we have to go. And Sonia, actually, you hit on a few of the points. I'll have to re-edit what I'm saying as I go. Just on some of the top line ones, just inequality is particularly stark. So if you look between urban and rural areas in the country, if you live in an urban area, you have a 35% higher chance of dying from a preventable cause. And even within urban areas, you see really stark inequality. So we have neighborhoods where the average life expectancy is 71, and we have neighborhoods where the average life expectancy is 88. This isn't in different continents, this isn't even in different countries, it's all in our place here. And those inequalities essentially are often starting with our children, whether it's the rates of food-related illness, if it's the poor quality air that they're breathing, the quality of housing they're in, the fact that they're being raised all too often in families on low incomes. It's a recipe for long-term poor health. And just in line with one of our commitments as an organisation, we say we always want to bring the voice of communities most affected by issues into the room. So I'm just going to speak to a couple of quotes people in our place have said. One resident said, growing up, the only options we had with pocket money were the unhealthy route because that was the cheaper route. And that just speaks to this truism that what's around you and affordable, accessible to you is the way you're going to go. It's not perhaps some neat free choice. Then the second and last quote I'll raise is a parent who told us, people can't be healthy if they're living in bad situations. They're still going home to a damp and moldy flat, and they can't do anything about that. So it just goes to heart that these aren't abstract policy problems. These are daily struggles for families up and down the country. And the cycle that we're at risk of is very clear. The social conditions, in food, in housing, in work, in air quality. They drive poor health, they force the NHS into crisis, which reduces the ability to take that long-term view and work on those root causes, rinse and repeat. And so fundamentally, we know that we have to do two things kind of ultimately at the same time. Now, with Dr. Slow beside me, I'm not going to major on the kind of challenges within the NHS. And it's clear that we have to take steps on that kind of immediate crisis. I just want to major a bit more what we can do outside of the NHS really, and that eye towards taking on some of those genuinely preventative causes was what I push for. And often what holds us back is this idea that prevention is very much in the long term and we need to deal with it here and now. But we're increasingly seeing that prevention can have meaningful effects even in the near term. You know, if school children are getting better quality food, we see rates of school attendance improving. When the air quality is better, you see less emergency emissions related to asthma. We know that when people have safe and secure housing, they're similarly less likely to end up in hospitals. So it really feels important that we just kind of take the line that prevention is actually for the here and now, and not a long-term thing that we can afford to pause when times are hard. And at Impact on Health, we've been a really big supporter of the idea of the health mission, because clearly we need a cross-government approach. DHSE, even at its best, cannot solve these problems alone. And I think the push that we put to government is beyond cross-government. How do you go genuinely cross-society? And I think that's been one of the early challenge of what we've seen across the health mission and probably other missions as well. How do you make sure that you're involving local government, communities, civil society, and even industry in genuine ways? Because when people affected by these issues are involved in solutions, they're far more likely to stick. Otherwise, there's a risk that you'll have mission plans and ambitions that are very bold on paper but become thin in practice. I'll close shortly, but just to kind of reiterate, particularly in relation to children's health, I think that there's real power in seeing it as kind of core to both kind of mission, but also to national policy more generally. And that idea that if you're looking at what is the impact on children's health of any policy being enacted, would be a really powerful thing, because there's so much promise in the health mission as it stands. We just need to work with communities to achieve it.
Brilliant, fantastic. There's a huge amount in all of those opening remarks. I'm going to go to the Minister first for a question. I do want to ask a question specifically about your comments on the potential of data on prevention. I want to ask specifically about the role that you think that data and digital will play in tackling health inequalities as opposed to prevention at large. And I want to throw a second question here, which is, I think one of the reflections from everyone is that this requires a joined up approach, it requires a different way of thinking about government, and we'd be really interested in your reflections, particularly coming new into the role as a health minister, about the way in which the department can work more effectively across government, but also can work at that kind of vertical level, work more effectively with local government, other partners within the industry to tackle those kind of structural challenges.
So I'll touch upon the data very briefly, because I want to touch upon the more principal points that have been made so eloquently and passionately. The data is just so important because, as has been already outlined, we're living very, very different and parallel lives in similar societies. I'm a Glasgow MP. It's the same there. If I go to G41 where I live, the life expectancy is over 80. And if I go to G41 and it starts with a 5, it's over 80. If I go to G41 and it starts with a 7, it's 65, right? So we need to segment our populations. And I was talking about empowerment earlier, and that works for certain populations. For others, you have to bring the the mountain to Muhammad rather than Muhammad to the mountain, all right? And the data is critical in that, in segmenting those populations, finding out the risk factors. And we know that from broadly the NHS, where we know 10% of patients, maybe even less, conceivable than 50% of the NHS's resources, usually in a very haphazard way and in a way that actually is not beneficial to the Treasury, but actually is beneficial to the patient. So we need to replicate that model, I think, more widely in the preventative frame. To the points that have been made more generally, that is why mission-driven government is so important. That's why we did things like the Employment Rights Bill, the Tobacco and Vapes Bill, the Online Safety Bill. This is all stuff which of course has a preventative lens, but actually, more widely, it's just about decency and dignity and raising living standards. And that in itself will do so much for what we're talking about today. And that in itself is what the Labour mission actually is. Beyond the policy mission, the mission of this party, the mission of, the reasons why I got into politics is to do those things. And we now have the ability to do it. And, we'll all have different opinions of whether we're going hard and fast to do those things, but the proof points in year one are there. If we didn't come into power, we wouldn't have increased wages more in 10 months than had previously been the case in 10 years. We would probably have not passed a bill that means that anyone born after the 1st of January 2009 will never be legally able to smoke in this country. We wouldn't have done the soft stuff with supermarkets and food companies around getting them to a point where there is more candid information on what we're consuming. Of course, that's not to say there's not a lot more to be done, particularly around making the healthy choice the easy choice, and there's so much more to be done there. But I think we are on our way. We've got 4 more years. We need the good people in this room to keep pushing us in that right direction. But I think that it's important to be hopeful. We have a Labour government. We have a strong, stable, big majority Labour government. So we can do these things, and we have the opportunity to do a lot in the next 4 years.
Sonia, your question, in your role as a clinician, actually, I know that you said in your opening remarks that a lot of this ends up at the NHS's front door, but you feel somewhat powerless in your clinical capacity to deal with the problems. How do you think the NHS can play a more constructive role in terms of being a force for prevention in communities? Is that through partnership, or is it through changes in clinical practice? What's the role of the NHS, and in particular primary care, in this space?
Yeah, I think you mentioned this. There is the NHS can do 10%, whereas 90% needs to be policies outside the NHS. So I'll give you an example with asthma, for example. So within the NHS, there's things we can do. So using digital, I think thinking about we in our surgery run sort of searches on our systems to see if we identify any patients, any kids who are getting increased number of inhalers. So we've done that search, say, okay, this patient is having inhalers more often than they should be. We call them in, we look at their asthma technique. So that might prevent some hospital admissions. But then, of course, if we are then sending that kid home who is breathing in toxic air, who's living in a house with damp and mold that's damaging their lungs on a daily basis, then that's only so much. So there's a limit that we can do in the NHS, and it has to be accompanied by wider policies. Similar to, we see a massive issue of obesity. Obesity causes poor health outcomes. And what can we do in the NHS? Well, I'd love us to have better weight loss services. So right now, where I work, unless you've got a BMI of over 40, when my patients come to me, there's not much we can do for them, which is ridiculous, right? And then they're ending up going and buying weight loss jabs online. So actually what I want, when I have a patient that's struggling with their weight, they can come to our surgery, and then we have proper weight loss services, helping them with their diet, learning what healthy eating looks like, helping them to be more active, maybe getting them free gym membership. All of those things will be helpful. But then again, I take it back. With many of my patients who are living in poverty, due to their poverty, that they are having diets that are cheap and nutritionally poor. We see that. And if you actually follow the NHS healthy guidelines, if you're living in the bottom 10% of income bracket, you're spending 90% of your disposable income on food. So that's completely unaffordable. So then we need actually legislation to improve the quality of food and make healthy eating cheaper for everyone. And I can see we have some respiratory physicians in the room, so I'm going to mention this as well. We need policies to improve our air quality. We need a Clean Air Act to ensure that our air quality is getting better and we're not damaging the health of our kids. But then also NHS, in my area, our smoking cessation services have disappeared. And I think something which also we don't maybe not talk about enough is that a lot of the public health measures that we need within an NHS don't come from NHS funding, come through local authority and public health funding, which received significant cuts over the austerity years, and many of those services haven't been restored. So we need to sort of restore the funding in public health. And then the last thing is, so surgeries I think there needs to be a review of how we fund primary care services, particularly looking at areas like mine, where we have highest levels of social deprivation, making sure that we have more funding than areas with lower levels of social deprivation, so we're able to put on more services to support our patients who have a higher need, who have less disposable needs. And I know they are doing that, they're reviewing the kind of formula, but I think that's something that can be done right now. And then my last thing, because this is a real frustration of mine, is that I have many patients with chronic conditions who don't get their medicines. So I have many patients with diabetes, with high blood pressure, with respiratory conditions, who don't get their medicines, maybe get the medicines once every few months and then they come in really sick, and that's because they can't afford prescription charges. So for each medicine, you're spending £11. So if you're on someone that's on 3 or 4 medicines, which many of my patients are, for many of my patients, they actually can't afford their medicines. So that's something that we can do right now to get rid of prescription charges, to ensure that my patients who are with least means are able to at least get the medicines that we prescribe them to keep their health, not improve their health, but at least stop their health deteriorating.
Brilliant. I'm sure we'll hear more when I open up in a second about policy direction of travel and other determinants of health. Can I ask you a quick question, Peter, just about sorry, just a quick question for Peter about the role of partnership in all of this, which is one thing that Impact on Urban Health does a lot of, is working with partner organisations, funding and piloting new approaches. So any reflections on how government can be a better partner to charities, to the third sector and others involved in this to better understand the needs of communities and to better solve those problems collectively?
Great, thanks. Partnership is hugely important. I think often there are 2 big things that are kind of needed. Initial support that gets something off the ground, and I think it's right that foundations like ours and civil society we should see ourselves as having a role to play, and Impact on Urban Health will quite happily fund pilots. I can speak, for example, we work with a school in South London, and we've supported parents and children to think about what would they like to help with their health. And that means they run cooking classes, parents who don't have English as a first language get benefits advice and help apply for things, and really wide range of activity that wouldn't immediately say health to many, but actually really helps them in their health. So I think it's fine that you have a range of funders, business, philanthropy supporting that early stage piloting. What we really need from government is to be along for that journey, even if not funding it, and to help give roots to sustainability. Because often the challenge is you find something that actually shows real promise, preventative potential, but then getting it funded in the longer term is really quite difficult. So I think that's where the more we can try out partnerships, use the innovativeness of philanthropy or business, and look to kind of government to help support some of that sustainability, things that actually are shown to have real promise and impact on the things that we all agree are important.
Brilliant. I'm going to have one more question to the Minister, if I may, which is about the challenge here around the short term versus the long term. I'm really interested in if you think there are areas in which there is a kind of a double dividend where we could make progress against that long term health mission, but also help solve some of the problems. So for instance, someone gave the example of smoking cessation services. We know in the long run that they save lives and save costs, but also in the short run they mean that people are better prepared for surgery if they're engaging in smoking cessation services. Are there other opportunities there to make sure that the short and long term are not in tension with one another, but rather complement one another?
There's lots of examples like that. I mean, smoking, when we put in the smoking out in an indoor public spaces ban in Scotland, believe it or not, it was the Labour government in Scotland that did that first before we did it in England. You know, within a year, less than a year, we saw a reduction in the number of heart attacks in the country. So there's plenty where I think prevention doesn't need to be seen through a long-term lens in terms of clinical benefit. Where I think the challenge is where the upfront cost is greater and people are seeing it through the lens of a financial year spreadsheet. And we have started to make inroads in that already with value-based procurement in the NHS. I was at Barks the other day, where this is a very niche topic, but actually speaks to some of the things we need to do more broadly in strategic commissioning, where, you know, on the face of it, this antibiotic coated mesh around a pacemaker cost 800 quid. So there's no way you put it in every single patient. But they found a way of targeting it to high-risk patients where infections are highest, justified the cost on the basis that it was preventing X number of infections, each costing 30,000 quid to this public sector. And they got it over the line, you know, backed up by the NHS England and the department, because we encourage them to think about value-based procurement, not just the cheapest item, you know, on the catalogue to begin with. And I think we need to take that philosophy when we build up these new systems, these health partnerships, health regions, community neighbourhoods, and make sure we infuse from the top, because some of this stuff is, I appreciate, needs to be top down as well as grassroots. That sense that we do want to procure things based on value and long-term outcome, on green book measures that perhaps we didn't traditionally think of, but also when we talk to industry and we're procuring medicines and we're procuring tech and we're procuring other stuff, we have a contractual, you know, arrangement which is based more on outcome rather than on just a unit price. You know, and I think we are getting there, you know, and I was really impressed with what they're doing in value-based procurement at the moment, which is 20 trusts around the country. But I think that philosophy, if we can get it more broadly infused into the public sector, will be game-changing.
Brilliant. I think I'm going to see you probably in one of the few rooms in the country where ears prick up when you talk about value-based procurement, so I'm sure there's excitement. I'm going to open it to the floor. I'm sure there are plenty of questions, so please do put up hands. I'll try to get to everyone. We might take questions in threes. We've got a roaming mic coming around. I'm going to go to the lady in the front row, and then I'm going to go to the gentleman here, and then the gentleman here.
Hi, I'm Philippa. I work for Sign Health. We're a deaf charity supporting deaf people with their health and well-being. In terms of the social factors you've mentioned earlier, and you're wanting to encourage this element of prevention, what are those communities that can't access services for weight loss, for example, or smoking? Often these small services don't have enough budget to pay for sign language interpreters, so how are deaf people able to access health? They then have knock-on effects in terms of their long-term health, because the impact is dire because they're not accessing prevention services due to the lack of funding for interpreters.
Thanks, Sally. I'm Steve Turner. I'm a paediatrician and president of the College of Paediatrics and Child Health. We're clearly living in an environment that's terribly unhealthy for us, and the last government has sort of demonstrated how not to do it. So I'm going to have two observations. One's going to surprise you, and one might not. My first ask is that although I'm a paediatrician, we've talked a lot about children, there's a lot to be said for including children along with everybody else, and not trying to create them as a subspecialty, because often they might get forgotten. So as a paediatrician, I'm saying please include children as everything else. That's the surprising thing. And the perhaps not surprising thing is that if we are going to make children equal, fanfare, we need to treat them equally. So they're 25% of the population, 11% of the health spend budget. That's not right. And just a little bit, children's community waiting lists at times aren't going the same way for them. So equity for children, they have a right to equity. Can we please ensure that they get it? Thanks.
Hello, Henry Anderson from the Health Service Journal. I think the question is primarily for the Minister. Local government is expecting the public health allocations to stay broadly flat in real terms. Given the impact of the cuts under the previous government, can Labour offer any more hope that the public health grant will be restored?
I might go to the Minister first for responses to all three of those questions. So the first question was about how can particular communities, particularly the deaf community, access services, particularly where budgets are stretched. Question about paediatrics and how we make sure that we treat children and young persons services equally, and finance reflect that, and then a final question about public health around it.
I mean, I'll just be honest and say public health is not something that's in my portfolio, so I can't give you a guarantee as to what's happening with it. Except to say, we are conscious of the fact that, the left shift can only happen if we start to put our money where our mouth is, okay? And that in itself is a difficult process, right? Because you do have to extract money, ultimately to achieve this agenda from hospitals into communities. You have to double run part of that because you can't just suddenly stop things in one and the other. And I think that's where I think local leadership is really important, because how that happens in each area of the country is very different. I can't and shouldn't sit in Victoria Street and dictate how money should be transferred over in a different area with different needs, different demographics, different communities. And it's not to absolve myself of the responsibility, but it's actually to take a risk and devolve some of that decision making down to the ground. But fundamentally, you're right, the challenge to me is how do we reflect a left shift? What you're asking me is how do I reflect the left shift in the spending from the Treasury down to the communities? And that's going to be a challenge for the next spending review as much as how we do things right now, how we do that well. To the point of equity for children, again, it's about what government prioritises, what government puts into its formula to use to calculate value. And I think the chickenpox vaccine is a perfect example of that. I mean, that should have probably happened a long time ago, but it only got over the line as an economically valuable thing to do for society. It suddenly dawned on us that it's not only the child that's suffering, as important as that is, it's the wider family. It's usually, dare I say it, the mum who's not going to work, who's sacrificing, her time. And when we started to look at it from that lens, we suddenly realised this was a good thing to do. So I think we get to equity for children when we understand the price society pays for children being unwell. Over and above it being the morally right thing to do, it's also the economically right thing to do.
And to flag the IPPR and impact on urban health, we've been plugging away at that challenge about making sure that we capture the full value of investment in children and young people and really understand what kind of scarring effect that comes from children not being supported well early and what impacts that has across the life of the course. I think it's a really important conversation that we continue to have. I'm going to bring in Peter on any of those questions.
I mean, I think that they've been covered really well. Just kind of in getting some of the positive progress that I think has been made this year on the healthiness of the environment. Really been encouraged by the widened access to free school meals, to kind of the receipt of universal credit. Really important we're making progress on junk food ad bans. And whilst I think the kind of mandatory reporting of the healthiness of food sales is a really important step, and it would be fantastic if we were seeing a move towards mandatory targets in this government, but we dare not to dream too bold. So at least the kind of course being set that we want to go there feels really important. Just what we see in our place in South London, we know is true in so many others, that it's where is the natural flow and course of things, and whether it's in kind of online environments or physical environments, we see for children, for us all, that often the unhealthy choice is the easiest choice, and so it's good that there's some shifts against that.
Yeah, I'll come to your question. I think in today's day and age, with the technology that we have, there's absolutely no excuse for anyone not to be able to access services. So I think if there has, so like in my surgery, for example, we use a online system that allows us to get a sign reader on video, and which works quite well. So I just think there's absolutely no excuse, whether that's for sign language or for translating of languages. A lot of my patients can't speak English, so there's just no excuse. The technology is available, And if there are services that are not doing that and stop access, there should be repercussions for that, because it's inexcusable with the technology that's available. I'm gonna child health. I'm actually gonna disagree with Peter when he said we should dare not be too bold. On health outcomes, if we look at children in this country, we have poorer health outcomes than other countries with a similar GDP. And we are one of the first generations where we can't confidently say that our children will be living longer than us. Now that's shocking, right? So I think we have to be bold and we have to have urgency. We're in government. Why else are we in government if we're not going to implement policies that will improve the health of our children? So it's fundamentally important, and we have to be bold and we have to have urgency there. So yeah.
Brilliant. We'll take another round of questions. I'm going to come to the front and make Vicky's job slightly easier by grouping them here. So the gentleman here, the gentleman behind him, and then the woman behind in the pink shirt.
Hi, thank you. My name is Alex Bax. I'm Chief Executive of a charity called Pathway, the National Homeless and Inclusion Health Charity. Fascinating discussion. A couple of general points that we didn't see in the 10-year plan. Michael Marmot's great proportionate universalism phrase, which would be great to hear a bit more about resources. We've heard Cahill is being looked at, but really being slanted towards need, by place and by population. And then perhaps some specific questions about it. So we would say that homelessness, as Lord Darcy said in his review, homelessness is a health catastrophe. It's also very preventable. There are actually quite a lot of things that NHS services can do to prevent homelessness. For example, putting a pathway team in your local hospital. But a big national change would be to get the NHS to record people's housing status routinely. We've got housing status fields in the urgent and emergency care data set and in the mental health data set. They're not well used. It takes a bit of training and thought, but if you got the data about housing status across all health interactions, it would be a very, very powerful way to drive further change and to intervene, particularly neighbourhood health, where people have got poor housing status or insecure housing. You could then mobilise other services to come and support. So a very practical suggestion there. Thank you.
Hi, thanks for a great panel so far. I'm Harry, I'm a doctor and also I'm currently working for a Labour MP. I want to slightly double down on the question that Seb, the chair, asked at the end there, but only because I think it is so important. So, Zabir, you and the ministerial team at DHSC, it strikes me that you're facing the same core dilemma that ministerial teams have faced for the last 40, 50 years in the department, which is, on the one hand, the NHS needs to become preventative in order to be sustainable, but on the other hand, the NHS is one of the core issues to voters, and at the next election, the things that the Labour Party are going to be judged on, it's not necessarily the preventative stuff, it's access to GPs, it's waiting lists, it's A&E times, and I would argue that this dilemma is a big reason why we've been talking about prevention for 40 years and it hasn't happened maybe to the extent that we have hoped. And look, we can't. I think we need a deliberate plan to kind of balance these things, because we can't say, okay, elections don't matter, they do matter. So I'd be interested in all of the panel's thoughts on kind of how we can have a deliberate plan to balance both of these things.
Hello, I'm Kathleen Rockland. I'm a retired NHS chaplain in mental health specialties, but I'm also here today representing the Better Bones campaign for Universal Fracture Liaison Service, and I'm really pleased to hear the kind of things you're talking about, because they just match up with what I saw over my years in the NHS as well as now. And I also live with osteoporosis, but people will think, not everybody who has osteoporosis looks like me. Gray-haired lady of a certain age, people who, as you were talking about, people who are living with lung conditions increasing, people who have long-term steroid use, they're at risk, people who've had certain kinds of cancer treatments, they're at risk, people who live with eating disorders, they're at risk, people with celiac. I could go on, pregnant-related osteoporosis. I would guess that most people in this room will either know someone or perhaps be someone, even though they may not know it, who is dealing with osteoporosis. And so it is really important, and I was so pleased to see the government commitment to putting these services in by 2030. But we need a plan now, so those services will be in place. If we delay even to 2027-28, there'll be 7,500 further deaths from hip-related fractures. So it's really important. This is life-changing and not in a good way to delay. And I hope, Minister, you will work hard on making this a report on our bone health plan that will be needed to go any place further with this. Otherwise, we're just waiting. And for those who are involved on this panel, the rest of you, please advocate wherever you can for this. It's really important. Thank you.
Brilliant. So a few things there. Questions about allocation of resource and about the Marmot principles about proportionate allocation. Questions about homelessness in particular. A dilemma around reconciling the short and the long term. And questions about fractional liaison services. So I'm going to start with Sonia.
Okay, those questions. Okay, so then I'd say that the dilemma about long-term versus short-term, that's always there. I guess my answer to that is I think that we have to do more to explain to the public why we are putting in these long-term measures and the benefits that they'll see. So I think, I think there is, and I think that's, when I was talking about sort of having a vision, we have to be able to articulate what that vision is and explain that to the public. So when it comes to, policies around food, it's not, I think we have to explain why we're doing this, why this will make food, it's not a negative thing, it's going to make food cheaper and healthier for you. So I think just taking the public with us will make that easier. The question about osteoporosis, and I think there's sort of lots of ways to answer this, and I think something that I'd love to see more actually in the NHS is more support to get people stronger. So like women, for example, once you start to go through menopause, your bones become weaker, you increase risk of fractures, you increase risk of hip fractures, ending up in hospital. Now we can counter that if we are supporting women to do weight training, to do strength training. We could do that in the NHS, right? But when I have my lady that comes to see me, and yes, I can prescribe HRT, but I could also prescribe these other things that will help her to be stronger in the long term. So I'd love to see more of that. And actually, particularly now that we're having so many of my patients taking the weight loss jabs. Now the weight loss jabs, yes, we know that people lose weight. Actually, a lot of that weight is muscle mass. So it is going to increase their risk of having bone fractures later on in life. And I think we're just not talking about that. So sort of 10, 20 years down the line, we're seeing lots of people having fractures. That's going to be horrendous. So we need to be addressing that now, and this is the support that we can do. And then sort of beyond that as well, I have a lot of, when I have, let's say, my patient who's in her 60s or their 70s having falls at home, again, what can we be doing to support them holistically to manage that? So when they come and see me as a GP, yes, I can do the checks to make sure that they haven't hurt themselves from that fall. But what other things can we be doing? Measures in their home, measures in their workplace, measures in their diet and their lifestyle to support them to be stronger so they don't have falls at home. And I think we can be a bit creative and use services outside. So whether it's, I should say this actually, my other role is I'm Director for Health for UK Active. So actually I do really believe quite passionately in using our physical health services to support the NHS. And there was a pilot that was done in London where they connected local gyms with the patients that were waiting for hip replacements in South London. And what they did in that, because we know that waiting lists are like 1 or 2 years, we had these patients then going to gyms every week with physios, doing exercises, doing strength training. And and the outcomes within 6 months were incredible. So reduced pain, reduced need for operations, reduced use of medicines. So here again, you can just think about sort of creative policies of using services that may be outside the NHS, or bringing them within connecting to our healthcare service to try and improve long-term health outcomes. There were lots of questions about there. Yes, I completely agree. We need to have better recording of homelessness. We do this on our GP systems, but it needs to be better. But then I guess we always get to this barrier. So, we have a social prescriber in my practice. If someone's homeless or someone has, bad housing conditions, I send them to my social prescriber. She will refer them to the council, and then 6 months down the line, they're in the same position. So there's only so much we can do within the NHS, unless we're having change within local government and the services outside of that.
Let's go to Peter for any comments on those three questions.
Super. Thanks, Seb. Alex's point, just around homelessness, well, proportionate universalism, yes please, I agree with you see it drawn on more widely as a principle and directive for those most in need. But specifically on homelessness, it's an area where the kind of argument for prevention just gets like kind of stronger and stronger. One of the pilots that we funded, it works with people who are at risk of homelessness in the private rental sector, and whilst it on the face of it has been a kind of expensive service, we've seen like 70% of those who were supported ended up like still in their tenancy after a year. Just things like that, we're like, can we get in front of these issues? You know, council after council is struggling with the cost of temporary accommodation. I think it's like £4 million a day in London. And you know, what are the other services that are being so negatively hit by an issue of that extent? And like you said, Nick, if someone actually becomes homeless, it's a health protection. And just on Harry's point, I agree with Sonia here. I think we have to kind of make the case for why we need to take some of these long-term measures, and where we've supported like kind of polling of the public on some of these kind of long-term health issues, or even things like kind of free school meals, where the kind of distinctive position is the public are going to be kind of against it, or mandatory reporting, things like that. And I think often if you make a clear case, like, the public understand these things and get that like these unhealthy environments aren't good for them, won't be good for their children or relatives or other people around them. So I do think we need to make the case. And more controversially, I may lose the room on this, but I do think some of our framing about the NHS sometimes veers into the unhelpful. Like, where our ambition is save the NHS, it's like get the population healthier, or something that's a bit more towards the end result. And I think at some point we do just need a slightly more open conversation about what's the best way of improving our nation's health, and let's do that. I'll stop there.
Brilliant. I'll pass to the Minister, but got some specific reflections on the politics of all of this.
Yeah, I mean, I would start with a comment at the front about homelessness. You know, it speaks to, I think, fragmentation of different bits of data that different government agencies, you know, handle about you, and to synthesize. You know, I mean, to just kind of get through the information governance and all that stuff that currently is used as a roadblock. And I think that's how that's facilitated, rather than at every one individual point we kind of make the A&E receptionist's job more difficult, or the A&E doctor's job more difficult, the A&E nurse's more difficult. They should just be more synthesized and integrated. And of course there are information governance issues there, legitimate ones, but they're not insurmountable. I think that's the way through that one. Short term, long term, that's the age as old as time when it comes to just doing politics. I would say we've been reasonably good actually in the last 50 years in doing prevention in this country. You know, in terms of what we've done with cardiovascular disease, has been amazing actually in many ways. You know, there's lots of people in Glasgow who have dropped dead in their 40s of heart attacks. It doesn't happen anymore. A lot more to do, of course. No getting away from that. And I think you can do bits of it together. I mean, you take the GP piece, the GP access piece, which by the way is the top thing that the Great British public want us to sort out in this country. It's not actually elected waiting lists, it's GP access. You can use that as an opportunity in a moment, particularly if you do it through a digital interface, which by the way I accept not everyone will want to or can do, and that's fine. It's not, you shouldn't be the only front door to the NHS. But you can use that as a real moment, particularly with young people, to develop a relationship, not only with their doctor, but with their own health. And suddenly then that opens up a world of opportunity as to how then they live a healthier life for longer. And prevention also, as has been very eloquently adumbrated by my friends here on this panel, is not actually just the job of the Department of Health and Social Care. It's the job of the government, but it's actually also the job of the citizen. And I think we as a Labour movement need to get comfortable with our own language and our own narrative of what citizen responsibility looks like in that field. And on osteoporosis, Many of your friends and the society hold our feet to the fire quite rightly on that issue, but the wider issue, of course, of women's health, the women's health strategy also is ringing in my mind, and how actually, despite it being half the population, we still treat many issues surrounding women's health as somehow they've been dropped from Venus. We need to get over that.
Yeah.
Another round of questions, and we're going to go right up to the back this time. The woman on there, yep, and then to the woman here on the end, and then to the woman here.
Thank you very much. Thank you very much, Grace Duffy from Bridges Outcomes Partnerships. I wanted to sort of pick up on a point about data and about personalised outcomes. Actually, slightly picks up on this point about social prescribing as well, because so my organisation, we do a lot of work with long-term conditions, prevention, mental health, a lot of these kinds of things. And a really outcomes-focused work. And many commissioners will be sort of happy with it. It's hard to convince them sometimes to pay for certain outcomes. So that might be demand reduction, or it might be weight loss, or BMI, what have you. And those are super, super important. But actually what makes the difference to people making sustained changes in their lives is actually much more personalised outcomes. Actually the things that they are determining for themselves about what needs to change in their lives. And when our coaches, our social prescribers, help those people to find their personal outcomes, that is what unlocks the system's outcome. And I think it's great in the 10-year plan, there's so much of a focus on outcomes, but what I am concerned about is, are we seeing enough of that focus on the individual? And how can we make sure that comes through? Because that's key to the social determinants. Okay.
Hi, my name's Emily Mitchell. I'm from Bayer, we're a life sciences company. I wanted to pick up on the health of young women in particular. We know that in areas where there is the lowest GCSE performance, there tend to be much higher rates of unplanned pregnancy and increasing abortion rates as well. One of the simplest solutions around that is both education around contraception, family planning, etc., but also the access to particularly long-acting contraception. And I think we're in a moment between now and possibly next March where I know government and NHS are working on the 10-year plan, implementation plan, when it rolls off the tongue, and then potentially NHS planning guidance for next year as well. I think one thing that can be done from now is to institute a minimum flat rate for people that are fitting long-acting contraception. We know that the majority of fitters say they literally do not get paid enough to do that service, so they're running that service at a loss. And then also where public health come in, secondary care and primary care, another thing that can be done is to do integrated commissioning. So whether you're getting contraception for a contraceptive purpose or a gynecological purpose, which are things that can keep women out of work and are extending gender disparity and economic inactivity that we're seeing. Again, an opportunity with the 10-year plan, integrated neighbourhood teams, etc. If they can all come together and say, there's no wrong door, no matter where you are getting a contraceptive fitted, no matter for what purpose, if there is a fitter in a place that can do it, let's fund them to do it there and bring health message to those people as well. So I suppose the question is to the Minister is, what scope do you feel there is to have that type of discussion for these relatively quick win items that can be embedded into planning between now and March next year?
Hiya, my name's Sam Dowling. I work with GPs in London, but this is half my day job and half a personal question. So, interface and the join up between how services are commissioned and what they look like and what services are needed. As a patient, I am often frustrated that the services that are made available to me aren't ones I can access. I'm a mum, I've got a child. If I need to go and get physiotherapy and I can't take my child with me and I haven't got childcare, I'm knackered. I can't get the care that I need because the system says no. There are lots of other examples about that as well. Transpose that to general practice, and GPs are often told what the solutions are that they can apply, regardless of what the communities are that they're serving and what the needs are of the patients that need to be at the heart of it. So there's a lot of talk at this conference about AI and technology, and that will work for some but not for all. And often innovation at the expense of safety is a whole other debate. So my question for you guys is, how can we improve the interface? How can we get the connection better between the commissioned services and the outcomes that we want to achieve, and have patients at the heart? Because as long as it's commissioners talking and providers complaining and patients are in the middle, we're not going to have patient satisfaction, we're not going to have the right outcomes, we're not going to get the citizen-led change that I think you've all referenced at some point.
Brilliant. I know the Minister needs to leave in a second, so I'm going to start with you, Minister, and then...
Yeah, I mean, what you've said there is all about patient voice, isn't it? I mean, that's the missing link, and it's, you know, it's an integral part of the 10-year plan about how where that patient voice sits in community neighbourhood boards, in regional boards, and really helps to direct that at that policy level. In terms of long-term contraception, that was a very, very detailed question. It's all right. Which the answer is, if you give me your details, I can pass that on to Karen Smith and try and get you an answer about how we do that in the short term between now and next March and the planning guidance. And thanks for highlighting that issue with the fitters of long-term contraception. Question at the back, for me, is about how you see the individual through the data. And if I'm honest with you, because we are so far behind the curve in our digital maturation, that is going to take some time. It's where we need to get to with personalised medicine and interaction. But I think what we first of all have to do is do some sprints just to get some credibility, both with people that work in the NHS, that for once government can actually deliver on a data project, and then secondly with the public, that we can be responsible, not only responsible with their data, because I think largely, believe it or not, they do think we are responsible with their data, but actually good in control of it, and how it plugs in between primary and secondary care in the third sector. I think once we crack that, the individuality will come to the fore, you know, I think in a kind of quite an organic way. Yeah, but I'm sorry I must leave you, but you know where to find me in it.
Yeah, I'll actually answer your question, Emily. So the issues with unplanned pregnancies. So this, I can explain how this problem started, because I used to work in sexual health. So sexual health funding doesn't actually come from the NHS, it's public health. So as in austerity years, as local funding for local government was cut, a lot of sexual health services had their funding cut. And often with sexual health services, the services that they cut were things like advanced contraception for women. So they'd keep open their sort of STI clinics, but a lot of services had to reduce their hours or cut their services for contraception. So then it fell on GPs to do contraception, long-acting contraception. We talk about long-acting contraception, we're talking about things like implants or coils, so things that need to be put in. And then there's two problems. One, so in my surgery, some GPs do put in long-acting contraception. It's actually a money loss for us. The money that we get for it is not actually enough to cover the cost, but we do it because it's important. But also the second problem is that a lot of the GPs are not actually trained to put it in. So I think I agree with you. We need increased funding for long-acting contraception. But secondly, we have to, I'd say, maybe mandate that all GPs are actually trained to do long-acting contraception. And I think it goes to a wider point, which I think you touched on, of women's health just not being prioritised. And we see this in lots of areas of women's health, whether that's menopause care or contraception. And actually, I am disappointed that the women's health strategy and the women's health hubs, we had all this conversation, previously, and it hasn't materialised. So I think we do need a bit more pressure on the government to ensure that we are prioritising women's health and women's health services, and ensuring also that our healthcare professionals are adequately trained to provide that service and care. And maybe I'll leave it there. I can ask your question about interface. I think that's a very interesting question. I think it's also about remembering that I think we need to always make sure when it comes to providing services that we are allowing the people that know best about what's needed is the patients and the clinicians working in that area, and it will vary from place to place. So I love all these advances that we're seeing in digital, it's great, but I can tell you, for example, where I work in my surgery, we brought in online consultations, which we are, it's been mandated now, we have to open things in online triage. So instead of calling up, you're supposed to book your appointments online, which for someone like me, is great, it's really quick, I love it. For so many of my patients, I don't know, maybe like half my patients really struggle. A lot of my patients are just not online. So I think we need to remember that different areas, we have to make sure that everyone's able to access the services, and it will vary from area to area. So we need to make sure, as we're pushing for this digital transformation, we need to also make sure that we're allowing clinicians working in that area and patients in that area have a say in what services are being commissioned and how services are operating to make sure that no one's left behind in that shift.
Thanks. I mean, I'll just speak to the overarching point that people are fundamentally experts in their own lives, and part of the reason I kind of made on the point that if you don't involve community, you don't get fantastic solutions. And so I think there's an opportunity with some of the kind of neighbourhood shifts in the NHS 10-year plan. We've got some piloting happening in our part of London. And we just kind of, I think my push would be like, how do you fundamentally involve people at every stage of the implementation? Because without that, you're at risk of getting into the place of commissioning services that aren't hugely kind of needed or aren't delivered in a way that is most suitable to the population.
Can I just make one more point as well? We're talking about this idea of neighbourhood health centres, which I think is a great idea. Actually, an IPPR panel 2 years ago we talked about it, so I'm glad it's happening. But what it can look like many, many, many different things, and I think we actually don't know yet what it's going to look like. And my concern about these neighbourhood health areas is that their decisions are dominated by the big NHS trusts rather than by local GPs and by patients, and that cannot happen because that would be disastrous for everything that we're talking about today.
We have time for two more questions, so I'm going to pass to Sonia very quickly before she has to go, and then over to Peter, and then we'll questions after the woman here, and then our secretary.
Thank you. My name is Mariana Masters. I'm a counsellor in Lambeth, London Borough of Lambeth, and I wanted to touch on ethnic health inequalities. So given that black women in the UK are 3 times more likely to die in childbirth than white women, what pressure are we going to put on the government? It's a pity that the minister's not here, in strengthening the women's health strategy so that that's addressed and there's accountability for that.
Jiggy Alov, A&E doctor and a IPPR trustee. Just a quick observation. We spoke about how, Sonia, you were talking about maybe prescribing weights for your patients who are at risk of osteoporosis. The minister spoke about a fancy pacemaker that has an antibiotic coating to prevent infection. Again, we're putting all these fancy classes of problems that we have in the system. One of the biggest risk factors for post-op infection is mold. If you come from a moldy, damp home and you have a hip surgery, if you have a hip replacement, you're at a huge risk of developing infection and increased mortality. I don't think, Sonia, we should, as doctors, be prescribing weight training, gym classes, healthy foods, and free school meals. I wanted to ask the panel again, Peter, Seb, Sonia, do you think that's an appropriate use of NHS money to, when we have blindingly obvious solutions to these things, but we're just avoiding it with fancy innovations and passing them back on?
Brilliant, Sonia. Let you respond quickly before you have to.
Yeah, I think it's a great challenge. I think it's essentially what I said. Do we put sticking plasters or do we tackle the causes? And I think so while we wait for our government to implement the policies that will tackle the food industry and improve the diets of our food and bring in the policies to improve the housing conditions, we in the GP surgeries need to do what we can. So I don't think it's either. I think we have to do both. Is my answer to that question. So yes, I don't want my kids to be living in damp, and I need the politicians to have a policy in to ensure that we have healthy homes. But if a kid comes in and is having issues with their housing, I do want to have something at my disposal, whether it's social prescriber or something else, to try and give them some support in that. So I think we need to do both. Ethnic health inequalities. I think if you're interested in this, you should come to our panel tomorrow. They've decided we've got a panel on this, ethnic health inequalities. Rich, Mariana, and myself will be on at 6:30. 6:30? 5:45. 5:45. Do come along at the Blue Coat. But I think it is astonishing, isn't it, that black women are 3 times higher risk of dying in childbirth than than white women. And that's a result to issues within the healthcare service, but it's also due to the issues that we discussed earlier, right? Because they're more likely to be having layers, I guess, of discrimination and deprivation that's impacting their health. It's also why infant mortality rates for Black British babies and also British Asian babies is 2 to 3 times higher than white babies, right? So these inequalities that we see are throughout. And that's why I guess I have to run off, so I'm going to finish on this. You know, your line of, don't be, I can't remember the line now, we have to be bold and we have to have urgency. Yeah, and I think I'm just going to sort of really finish on this, that I'm getting impatient. We're in government now, and we've got 3 years left, potentially. So I think we have to start implementing these policies now to address this. I do have to run, because I've got another event, but if anyone wants to talk to me more, please do get in touch, and thank you all for coming.
I'll give this a brief statement. On maternal health inequality, disagree. Like the rates of disgraceful. We're piloting with our local ICB some community-led solutions to maternal health inequalities, and it just goes back to that point. Like, how do you make sure communities and people affected actually have a say in the solutions you try? And then I'll just be kind of shamelessly preventative. I think the further upstream you can do prevention, which is like, in many cases, like tackling mold in homes, the better, and that's one of the reasons we work on tackling mold in homes.
Brilliant. I think it's a great place on which to end. So I'd just like to say a huge thank you to all of our panelists, including the Minister who's no longer here. Thank you all so much for coming, and thanks to Impact and Urban Health for making this event possible. I'm sure that we can all agree that the vision is there around prevention and keeping this long-term mission on track, and it will require many more of these conversations and some real action to turn that into practice. So thank you so much for joining us, and enjoy the rest of your conference.